Hi, I'm Dave Fornell, the editor of Diagnostic and Interventional Cardiology magazine. I'm here at ASE 2016, and I have with me Stephen Little. He's the medical director of the valve clinic at Houston Methodist DeBakey Heart and Vascular Center, and you're very involved with the interventional side of echo. And I want to talk to you a little bit about today, the technology, where it's at in the cath lab hybrid for structural heart procedures.
Sure. Well, Dave, one of the things that's really sort of taken the field by storm is there's a lot of interest in the combination of fusion imaging. So it's combining, in a digital sense, the echo image onto the fluoroscopic image, really to have a single data set that the interventional and echocardiographer are looking at. So that tends to be fairly vendor specific. You know, Siemens has a version, Philips has a version, everybody's working on their version. But there's a lot of interest in that and how to bring the echo image and annotations made on the echo image directly onto the fluoro screen. In addition, there's also some sort of back chat about getting the fluoro image or pieces of the fluoro onto the echo data set. Fluoro is very good at identifying catheters and bony structures. It's not good at identifying soft tissue structures. Echo, on the other hand, is very good at soft tissue, pretty good at catheters, not good at bone and sort of, you know, those things. So really sort of combining the best of both. And there's a fair bit of discussion about that at this meeting. The other thing is, you know, really, and I was amazed actually even at this meeting how much discussion there is around 3D printing. 3D printing based on 3D echo data sets, based on CT data sets. It's even possible based on MRI data sets. It's not done as a matter of routine, but for certain sort of specific procedures, things that are challenging, you know, the first time you're doing something, there's a lot of people doing models, patient-specific, sometimes functional models, sometimes models made by blending different materials to really recreate the calcification and the specific pathologies, you know, creating a benchtop model that you can actually practice the procedure on before you do it. In terms of the, you know, the level of procedural planning, that's really very new.
One of the 3D vendors who set up on the show floor here, I think it's for the first time even, they talked about the different types of materials you could make. And a lot of times we're used to seeing hard plastic models made off of CT scans, but they were showing very floppy, flexible rubber ones that you could actually print as a solid mass, and you could actually practice with a scalpel if you had to do
And that's really how we're sort of catching up with the technology. So the 3D printing is getting so sophisticated. We have a vendor in Houston that we use, 3D Print Bureau of Texas, and they have very high-end machines, and you can actually blend together up to 3 different materials. And some of those can be, you know, hard plastics, some of those are soft rubber compounds, some of those are really hard like calcium. So now you can take a mitral valve apparatus and you can say, you know, I want the mitral leaflets to be kind of floppy, but I want the calcification that's under the leaflets to be rock hard. And then you can really get these material blends together, and then you can color code them. If you want to teach, if you want to discuss with patients and their families, if you want to talk to fellows, you can say calcium yellow, leaflets white, ventricle red. And then as you go through and learn these things, it's really amazing what's happening. And now there's a discussion with, you know, in my lab and others are actually working with bioengineers to really replicate in pretty good detail the material properties of these tissues. So I think next year it'll be even more impactful.
Do you think, working with 3D vendors, that this is something that will be done on a regular basis moving forward for TAVR procedures or Watchman procedures, or do you think this is mainly for those hard cases where the anatomy is difficult? I
think it'll depend. It'll depend. I know the vendors are very interested in making it easier to do 3D prints, making that actually a sort of an export feature on their software. At the moment it is not there. You need an intermediary step, whether it's a third-party vendor, an open source software. You need some other tool to get you to a print. It also is very labor intensive. You have to have somebody who's skilled do the anatomic segmentation, the identification of anatomy and saying this should be this material, this should be this material, and that takes time. So the costs for 3D printing aren't negligible. There's a human resource cost. You need people to be involved in the process, and they have to be paid. And then the prints themselves, depending on the complexity and the blending, can be several $100s or they can be several $1,000s. So there's a whole host of issues that need to be resolved in terms of moving it mainstream. At the moment, because of cost, time, and newness, it is sort of fairly, you know, novel procedures. But procedures that, I mean, I don't think it's going to be routine in TAVR. TAVR is getting well established, people are understanding. But when you have a new procedure like transcatheter mitral valve replacement, so that is new, that's challenging, that's 5 to 8 years ago in terms of, you know, comparable innovation like TAVR. We're really at the beginning of that, and that's more complicated. You've got mitral leaflets, you've got a left ventricular outflow tract, you've got calcification, you've got septal wall thickness, and you're trying to figure out whether this new device will work in this particular patient. So that's an area where people are, in fact, multiple different centers are very interested in creating three-dimensional patient-specific prints prior to this new technology. Whether it'll be required down the road as part of the standard workup, we don't know. But there's really nothing like holding a model in your hand, holding a device in your hand, and watching them go together. You think you can do it pretty well in your brain from a 2D image, but you don't realize how bad you are at it until you've actually held the two models in your hand.
Right. And to that point, that's one of the issues with structural heart early on was 2D echo to try to guide procedures, 2D TEE, and also trying to use angiography and putting devices into soft tissue that you can't visualize on X-ray, which has really led to the subspecialty of interventional echo. What are some of the qualifications?
The training for interventional echo is, being defined as we speak. Now, this meeting, probably the last American Society of Echo meeting, there's actually a track for interventional echo. So it takes time to sort of get the groundswell that this is actually a subspecialty within imaging. It's well defined for those that are doing it, and those that are thinking of doing it are really just determining how much training is needed. I mean, I had a talk yesterday on this topic, and putting it together, the basic concepts are you need to be very facile in 2D echo and 3D echo, understanding the limitations of each and when to go from one to the other. It's not simply a mastery or competence in 3D echo. You need to know that what 3D echo can't do and when you have to go to 2D. You also need to be very aware of the details of the procedures. What are the steps? What's your role within those procedures? You need to be confident to make the call when it's appropriate, and you need to be aware that you need to waffle sometimes and reach out to the rest of the team and say, I need to use some hemodynamic data. I need to use some discussion with anesthesia to find out what's going on. So the ASE has a role. We're training. We have interventional echocardiography courses. The first one was this year. It was sold out. They're creating a DVD. ACC has a similar sort of mandate, and there's now ASE learning tracks at meetings like TCT. So all of these societies are recognizing there's a training need. I think individually it's still site-specific. Trainees or learners want to sort of identify a specific source and go to this institution and spend a year and learn the procedures, but I think it's so new that there isn't a defined training pathway yet.
With so many hospitals that are doing TAVR, they're doing Watchman devices, they're doing miter clips, and pretty soon there'll be quite a few coming online with trials for mitral valves. What is your recommendation to the hospitals that are relatively low volume, that are looking to have an echocardiographer come into the cath lab? What are some of the things that people need to keep in mind in terms of scheduling and time?
It's a challenge. It's a challenge financially. It's the first challenge. So it's a more obvious thing to do if you're a high volume valve center. Partly because the valve team and patient selection is very important. In general, most of these devices, I'd say all of these devices, are indicated initially for prohibitive surgical risk, very high surgical risk. So you really need another outlet. Now, if you're a surgeon who does 3 cases a year versus a surgeon who does 100 cases a year, you might have a different concept of surgical risk, and a different threshold to do procedures. So, I'm a pretty strong advocate that, at least initially when these technologies are new, you really want that surgical expertise in the patient selection, which means high volume, which tends to mean a reference valve center. TAVR is clearly moving itself out of those centers into the community. It's moving away from the requirement for TEE. That'll, at some point, it'll have an appropriate sort of distribution, but it's an expensive procedure. The valves are much more expensive than a surgical valve. Many sites, as I understand it, want to get started in TAVR until they do the financial analysis and find out that it's really a difficult procedure to do high volume in unless you've got a very specific financial model. And these models tend to be volume based. If you do a lot of it and you have a very tiny margin, it's viable. If you do a few, you tend to have the longer cases, more complications, and it's not financially viable. The other devices are very similar. MitraClip is a similar concept. You really need that surgical expertise in the beginning for patient selection, and the surgeon to be part of that team. Transcatheter mitral valve replacements are what we're all looking at now. They're even more complicated. So at least for I know coronary PCI clearly went from academic centers, a few reference centers, to a global distribution. I think the valve pathway is going to be a little slower. I'm not sure it's going to get there because the team is bigger. It's difficult to justify an echocardiographer through most current payment models in a cath lab for several hours. So you really can't justify it on a fee-for-service basis because the fee codes don't justify the time. So it tends to be a hospital decision. We're going to have this person here because it's good for quality, it's good for outcomes, and it needs volume to make that happen.
For hospitals that are looking to get into a structural heart program and adopt some of these newer technologies, how important is echo and guidance for these procedures?
So there's sort of a sliding scale. And it does reflect the training requirements as well. So at the lower end, it will be things like you need some echo expertise. It doesn't necessarily have to be an interventional echo person who's done that level of training. But most echocardiographers and anesthesiologists are comfortable guiding things like an ASD closure, a left atrial appendage closure. But as you get sort of up the scale, and I would sort of mid-scale would be TAVR, a little, even more challenging sometimes is sort of a biopsy of an intracardiac mass. That's very sort of fluid and different between patients, but it does really benefit from 3D imaging. At the high end is paravalvular leak repair, holes around the mitral prosthesis and aortic prosthesis. Tends to require very quick adoption and interpretation of 3D imaging. Mitral clip right at the top, and transcatheter mitral valve replacement right at the top. So they're not all the same. And the complexity and the time commitment for each of these procedures is different.
In some of these procedures, if it wasn't for 3D, 4DTE, they'd be almost impossible to do.
Yeah, I saw a good slide yesterday. It showed this sort of frequency of paravalvular leak repair before and after the creation of a matrix 3D-TE probe. And it went from sort of this many a year to this many a year.
Right.
And it wasn't because the patient suddenly appeared. It was because suddenly people understood we can actually fix this. And it's absolute. It's that en face view, looking down at a valve, identifying catheters, saying bingo right away. So mitral clip, paravalvular repair, transcatheter mitral replacement, I would say absolutely echo, and particularly 2D and 3D guidance dependent. Transeptal punctures, very common in EP and all kinds of procedures. It's variable what gets used, but people use ASE, that's another option. ASE is expensive, they're disposable catheters. TE is not. TE requires another person, but you don't throw away the equipment when you're finished. So there's a lot of conversation, and the finances around these are very complicated, and largely based on the personnel, the training, and the volumes.
In terms of the communications between your echocardiographer and your interventionalist, do you think there needs to be more of a standard taxonomy and also standardized views? I know there was some discussion in some of the sessions about maybe even just rotating images because echocardiographers are used to seeing images of the heart upside down.
That's a good point. There is, when these procedures first began, that's part of the training algorithm is how do you learn to talk a different language? The interventionalist left and right is not your left and right. The medial lateral you'd think would be the same, but they're not. The clock face doesn't necessarily work when they're looking at a fluoral screen and you're looking at an echo screen. So a lot of the initial training and the bumps in the road are just defining the nomenclature. Some of that sort of really speaks to the benefit of a small team, because the more you work with each other, the more common the language gets. Within societies, certainly in the echo realm and in the publications, there is a notion, there's the surgeon's view, the anesthesiologist's view, that has a common nomenclature to define the mitral anatomy. But that hasn't really, the societies haven't gotten together on the terms. I think they vary a lot.
Great. Well, thank you very much for your time.
You're welcome, Dave.